لازم خلي رحمة
صلح بس
تطبيق مش نستنى يصلحوا بيها ليش تقول ليش Je tiens à remercier Jeunes pour m'avoir invité à participer à cette journée et de leur faire participant pour utiliser maîtriser, si vous voulez, l'anglais médical et c'est tout pouvoir pour pouvoir communiquer maintenant plus au quotidien. Je remercie le professeur de Dour et professeur de psychiatrie, c'est lui qui est pionnier maintenant de la pédopsychiatrie à Monastir et qui a créé un peu qui prend en charge et répond aux besoins de la pédopsychiatrie de la région du centre. Et je le félicite pour ça, malgré les difficultés de l'enfant, j'espère que les choses vont s'améliorer. Donc, vous allez présenter la communication depuis les sociétés and smartphone disorders.
Thank you, Mr. Chairman. After all these good words, I'm speechless, but I'm also voiceless. I have no microphone, so I'll try to talk without any kind of support. And this morning, Dr. Azam mentioned that there's no good or bad personality traits. Unfortunately, I'm sure there are bad personality traits, and I know very well two of them because I've been, teaching and training through these last years. And when you get old, you acquire two bad personality traits. You become lazy and arrogant. So laziness was when Dr. came to me and said, we need a presentation for the conference. I said, I don't have time to prepare a new one. I have one already there. If you take it or you leave it. So she said, okay. And then comes the arrogance. What's the theme? Personality disorders. Okay, it's about dissociative and somatoform disorders. Nothing to do with your theme, but you have to take it anyhow. So this is how I had these two personality traits, and I hope I was nice this time. I tried to add some kind of personality traits with hysteria and so forth in this theme. I hope for the next conference, if you still need me, you know that I'm going to talk about trichotillomania, hair pulling. And probably you have to pull your hair, you're trying to choose something that fits to this. Otherwise, I hope you're not going to choose sexual behavior disorders or something like that, because it has really nothing to do with it. So dissociative and somatoform disorders in childhood, mainly because this is my field of practice. And I'll talk about this upon practical clinical situations. So first, why addressing this issue? Why this is something that is problematic? First, because this is a very frequent manifestation in our clinical practice, especially we in Tunisia. We work with adults or with youngsters. This is a very multiform and misleading presentation, usually. And this is also something that is peripheral in our practice, and we don't have a grasping point of view of what to do or what not to do with those patients. Body complaints are often leading to delayed diagnosis and excess of useless explorations and interventions by our colleagues in other specialties. We have a lot of cultural aspects related to body and to somatoform disorders, because the body is very important in expressing our aches, our suffering. And we have still now, until despite all the innovations in classification system, very challenging aspects in delimiting and defining clearly these concepts within the classification systems, since the concept of neurosis, was abandoned. So we start with some definitions. What is conversion? Conversion by dictionary is a transformation. It's changing one state to another for the same object. It is a symptom in psychiatry suggesting a neurological or somatic origin, but that can be entirely explained by known physiopathological mechanisms or anatomic pathways. Its onset, its exacerbation or maintenance of these symptoms, called conversions, is commonly attributed to mental factors such as stress. This is the definition. What about anxiety? This is an emotion characterized by an unpleasant state of inner turmoil or fear of an unclear threat. With physical, hence its importance in this topic, because it's about somatoform and somatic complaints, and mental manifestations, and it's an adaptive response to external or internal stress. So what's about stress? Oh, sorry. Stress is a biological or psychological set of disturbances in response to pressure or potential. So what we're going to address today is a set of somatic symptoms that have been called many names since many years. For example, here, functional somatic symptoms, unexplained medical symptoms, which is still, for now, the word that is attributed. Pseudo-seizures, paralysis, and usually they were always between conversions and anxiety. However, we know today that this is a very narrow way to see it, and DSM came with somatoform disorders concept. But we know now that all these manifestations occur in many different situations, such as depression, conversion anxiety, and other disorders. And this is one of my objectives through this talk, is to get rid of this association in our mind, some kind of conditioned reflex, hysterical conversion. This is my enemy through this presentation. So these problems of delimitation and classification are leading to challenges, of course, for diagnosing and interventions. So quickly, what do classifications tell us about conversions and somatoform disorders and dissociative disorders? So we have in child psychiatry a classification coming from the French child psychiatry system, that is Classification Française des Troubles Mentaux de l'Enfant et de l'Adolescent, CFTMEA, using a word that is evolving neurotic, so the word neurosis, neurotic, nephrotic, is still there. Disorders with hysterical dominance. Why do they say this? Because I have to remind those who are not child psychiatrists among you that normally we don't talk about personality disorders in childhood, because the child is supposed to achieve, to finalize his personality development within the 18th year at the end of the adolescence. So that's why we say with hysterical dominance, with hysterical aspects, something like that, to be careful. DSM came with somatoform disorders category, now called the DSM-5 somatic symptom disorder, and personality is unique. Sorry, it has been not, I didn't translate this, but it's still unique personality. And ICD-10 has got the dissociative, between parentheses, which is very funny, conversion disorders. This is written exactly quoted from ICD. So ICD keeps the neurotic concept here, stress-related and somatoform disorders, within whom or within which we can find some sets of anxiety disorders, somatoform disorders, and these dissociative conversion disorders. DSM-5 has got the somatic symptom-related disorders, this new category, or this new name for this category, and I go through it later on in my talk. So this is the outline for the rest of the talk. What are the controversies and possible pitfalls, pièges, that can meet us dealing with these disorders, especially in childhood practice? And these are the 7 situations or 7 characteristics that I want to address. So first, is it a symptom, a syndrome, or a disorder? And My leading line for this talk will be clinical cases. So let's start with the first clinical case. So we have a girl, Siwa, 9 years old, fourth grade in school with good achievement. She was referred by her pediatrician for acute episodes of suffocation and thoracic oppression with transitory inability to speak. Every time she went to emergency room, ER, received oxygen, injection of tranquilizer, like microbamat, and the onset was 7 days earlier when the father learned that Siwa was victim of forced sexual touching by a stranger on her way back from school, and he reacted negatively. He spat on her. Like so this is the beginning of these episodes. So besides the crisis of suffocation, we noted in this girl avoidance of the street where the aggression took place, nightmares, sleepwalking, and excessive reaction to stimuli, and exaggeration of complaints, theatralism, but at the same time. So what do we have as classification? We have I'm sorry, I think this is not the final version, but anyhow, we have to deal with it because I have some mistake. Acute stress disorder is a category where we have criterion A, exposure to actual or threatened death, serious injury, or sexual violation, with presence of 9 or more of the following symptoms from any of the 5 categories. I'm not going to cite all the symptoms, but the 5 categories are intrusion, negative mood, dissociation, avoidance, and arousal. So dissociation is here, and is possibly something that is part of the diagnosis of acute stress disorder. But this is not the purpose of my talk here, dealing with is it a symptom, a syndrome, or the disorder. So this is a very existential question for residents. What to do when I am going to do my diagnostic formulation in front of my boss? This is the question. To consider them, these somatic complaints, as manifestations of anxiety. To say she has got some physical symptoms of anxiety. For example, like, pain and things like that. Sorry. Or to say, these are conversion symptoms included in the diagnosis of the acute stress disorder, as I said. Or to diagnose a comorbidity between conversion disorder and acute stress disorder. This is the question. So one of the problems is once you say the word conversion, in your semiological record, then maybe your boss will drop his glasses like this and say, when you talk about anxiety or something else, but you mentioned the diagnosis in your semiological record, which is conversion disorder. So this is a very tricky thing, where to put it exactly. Clinical case 2, we have Emna, 12 years old, student in 7th grade. She's only child, fille unique. So she was admitted to pediatric department for a sudden lameness of lower limbs, impotence fonctionnelle des membres inférieurs. She has got apyrexia, no biological inflammation, no problems in the neurological examination. But one day before, a colleague of her at school revealed her unspoken adoption. She told her she was adopted. The medical examination showed that she was very anxious. She feels betrayed. She has got feeling of strangeness, exaggerated complaints about her body, seeks gains, benefits through remaining in the hospital, emotional blackmail to suicide with parents. Chantage au suicide. What's syndromic grouping here? Acute anxiety symptoms, histrionic traits, unexplained medical symptoms, or should we already refer to them as conversions here at the semiological level? So finally, we can find a way to do it with putting a diagnosis like this. Adjustment disorders, for example, the acute adjustment disorder with anxiety, with conversion disorder in DSM, while we can use still this category of neurotic disorder of hysterical presentation or hysterical dominance. So the take-home message out of these cases, out of these 2 cases, in order to keep a unicist diagnostic approach, considering conversions as symptoms rather than diagnosis seems more relevant especially if associated to anxiety disorders. If conversion aspect is clear, better to report it at syndrome grouping rather than at diagnostic formulation. This is the take. And to corroborate it, we can look at literature. We have a big comorbidity between conversions and mood disorders, for example. Unexplained medical symptoms have an important psychiatric comorbidity, especially with anxiety and depression, and their incidence rises with their severity. The more severely depressed or anxious you are, the more likely you will present with conversion disorders. And somatic conversions are found in 33% of cases of depression for the probability. This is a static market less than present for children with depression in injuries. So, this way to see things, the symptom goes to diagnosis, goes to intervention, doesn't seem to apply here for unexplained medical symptoms. This is not the diagnostic category that leads to univocal intervention. And this is another one. So this is one of the questions. The second question, is there really no organic impairment? Let me say. So this is the cartoon, and the cartoon says this is a Kinder egg on the couch of the psychoanalyst, and it says, I'm afraid there's a surprise deep inside of me. What's this about? So clinical case 3, Samia, 11 years old, is a student in 5th grade. She has got epilepsy since age 6, treated with valproic acid. Her family, and she as well, note 2 types of crises, of seizures, if you want. Neurological seizures, they say, they are no ba'asabi, and no nafsi. Psychological seizures in case of school exams or in case of frustration, with no traumatic fall, with no loss of urine, for example. So these are 2 different situations. Here another boy, 7-year-old, 2nd grade. He was admitted for a systemic onset juvenile idiopathic arthritis, which is a very big name for Still's diseases. Still's disease, maladie de Still, a kind of rheumatic disease in childhood. So pediatricians were perplexed because he has moments of motor loss of upper limbs without biological inflammatory syndrome. They suspect other disorders and prescribe many other radiological and physiological explorations. Nadir is challenged in his school achievement and seems happier in hospital. So you have to take conclusions out of this. Why these other symptoms? So the take-home message here is that conversions and other unexplained medical symptoms may occur on proven organic pathology. And this is not to be forgotten. Do not forget that children tend to regress or to benefit from their illness, so they can keep their symptoms. This is the same for adults as well, but we see it in children more because we have this clinical practice with children. Somatic conversions can resume or prolong symptoms of a cured or stabilized disease. In practice, psychiatrists should be very careful not to quickly accept to exclusively manage patient upon conversions secondary gains, because the way back is often very difficult. Once you receive the patient, try to give it back to your pediatrician or to your somatic medicine colleague. It wouldn't work at all. So the signs suggestive of conversion are variability with time and attendance, depending on who is here. And this is one question to be always asked: who was there when you had this already? Theatrical aspect, no amnesia, often patient remembers what has been said and the context around his symptoms, the absence of lesions with normal neurological examination, and the symptoms do not meet, this is a very known thing, anatomic and physiological pathways and systems. On dit non systématisé. So to collaborate, the association of conversion disorder with earlier identifiable diseases and lesions ranges from 10%, 60% in literature, which is confirmation of what I was saying. And in psychoanalysis, don't forget, the historical conversions always occur thanks to what we call somatic compliance, la complaisance somatique. So there's something in the body before the crisis or before the conversion. So what is about psychological conversions now? DSM-5 doesn't speak, of course, of this, but speaks about something else. So we have the somatic symptom and related disorder that I presented, but we have also another category, which is dissociative disorders. So this is related to, for example, dissociative fugue or amnesia. And the word dissociative is tricky. We have to distinguish between the classic and the DSM-ICD way of seeing it. The classical way of seeing things. This is a symptom of schizophrenia, dissociation related to what we call the disorganization within the personality. But here in DSM is a disruption in the usually integrated functions like memory, consciousness, and identity, with this, which is very often met in histrionic personality. So the clinical case 5 here. It's a 7-year-old boy, second grade, only child as well. For 2 years, and following the divorce of his parents, he was losing his voice from time to time and start to stutter to begin when he speaks to his father on the phone. And this continues a few days at home and school, every time he talks to his father. The mother avoids any conversation on the subject with him, on the subject of the divorce, and seems very anxious. So what we can say here, that the stuttering is not an actual stuttering, it's probably also a conversion, but we cannot say somatic conversion. In this case, we can speak of somatic conversion, which is the aphonia, but also psychic or psychological conversion, stuttering, or dissociative, with research of secondary gains attracting the father's failures. So to corroborate, comorbidity of conversion disorders with dissociative disorders is very high, up to until 91%. So the take-home message from this part is to be careful to differences in classification system within the meaning of the word dissociation, and we have to remember that separation of physical and psychological aspects does not seem relevant in the unexplained medical symptoms, as for example for anxiety, where we have both psychological and physical. Take-home message: conversion can mimic any physical or mental condition. This is what we have been taught when we were residents. Tuberculosis can mimic any kind of somatic disease, and conversion can mimic any kind of physical or even mental disease. Always think of it in front of complaints where contextual aspect is important. Is the expression hysterical conversion relevant? Next question. So, the histrionic personality disorder, according to DSM-5, has got some set of criteria, but you have here only diagnosed in adults. So it's a person with an inappropriate seductive, flirtatious, and provocative behavior, some types of theatralism, dramatic, theatrical, and excessively emotional person, suggestible, overestimates the role of intimacy in relationships. The classification of the French Association of Child Adolescent Psychiatry gives this diagnosis that I mentioned before of neurotic disorder dominating histrionic, supposing the presence of conversions and neurotic traits. The study made by Zainab Atassi in UNSC on children with conversions over some years, that was in 2013, we have been looking what was behind in the thorough psychological assessment, and we found only in 25% some kind of histrionic traits. So this is not 100%. So we remember here that the conversion is not necessarily hysterical, although hysterical traits are often found. This is especially true in children and in case of cultural context, promoting the expression of suffering through value. So conversion can occur on any kind of personality or any kind of developmental pathway. To corroborate, in developmental theories based on psychoanalysis, there is a normal phase of infantile neurosis and childhood neurosis between 2 and 5 years, with multiple neurotic mechanisms that are completely normal. And child can use multiple defense mechanisms until the completion of his personality in late adolescence. Context. Here we have a 12-year-old boy, 6th grade, with crises made of crying, with anxiety and confusion. When the crisis is over, he speaks with a certain indifference, and the neurological examination was normal, including the physiological exploration and the CT scan. The father associates the crisis, these seizures or this, with full moon. جاء الشهر 14 في الشهر ولا 15 في الشهر باش يولي عنده توا الكيس. The father is anxious because his own brother is followed for temporal lobe epilepsy. So you see here the connection. I am personally harassed by some fellow physicians, colleagues, doctors with their 8-year-old daughter who has got whooping cough 2 coquille for 15 days. The coughing occurred following an argument, serious argument between the parents. Despite the normality of my exam and the reassuring attitude after an interview where I know clearly a research of gains and indifference to symptoms, what you call la belle indifférence even in English, they remain very distressed by the crisis and feel guilty, and the cough persists. So though this was addressed only when the couple decided to address their own problems. So the psychological characteristic of conversions have to be remembered. La belle indifférence, as I said, variability to suggestion, suggestibility, existence of psychological gains to symptoms, and the existence of a particular psychological context within the family or the school system or whatever. And here we talk about the secondary gains, the bénéfices secondaires. Easy to highlight in our exam because we have clear avoidance of responsibility, of stress, for example, avoidance of exams, of confrontation about the misbehavior, a bad mark, or to obtain the interest of the of others. So take-home message from here is always look for similar events in the entourage, in the surrounding context. Once the diagnosis is set or settled, prevent excessive parent anxiety and proceed to patient isolation and impose firm attitudes, for example, for visits and for example, care. Always ask questions about previous care, especially traditional healers, who have significant power of suggestion. And don't forget that, for example, if you go to a traditional healer and you have some symptoms, they may suggest to you some kind of symptoms, some kind of other symptoms that you will be very happy to display to your doctor the next week, time you see him or see her. So we have to have a diachronic and dynamic approach, like a snowball, it is construction. So to corroborate this, more incidents of conversions is observed in the same family, and we have higher exposure to negative events in the same family with low academic and social performance. Our attitudes here quickly, about 5 minutes, okay? Quickly, I'm going to quote a paper by some colleagues who are pediatricians and took care of a child. And I think this says something very exemplar of what we want to say about our own attitudes. So a 10-year-old boy was referred for evaluation after 2 weeks of apnea. Just before this apnea, what happened? He has got throat inflammation with complete remission in 3 days. Apnea was unusual for doctors because it was not attributable to the laryngitis, to no coryza, no cough, no fever. The physical examination, including the laryngoscopy, was normal. But the interview with the child found an excellent student, but anxious during exams. So what they said, we convinced him that he will recover and his voice will be like suggestion. We reduced explorations. The saline inhaler was used once as placebo, immediately after which improvement was observed. At the same time, we discussed his school problems with the child and attempted, together with his parents, to lower his stress concerning scholastic achievements. By the second day after onset of treatment, the child's voice returned to normal and he returned to school. He has been symptom-free for the last 6 years. So it's a very simple presentation made by pediatricians, but it says something on what to do, what not to do. So the possible pitfalls here in PHOC is the escalade of explorations, the validation of the status of ill. Sometimes it's not even worthy to accept this child in your care. Excessive length of hospitalization and management of visits by family that needs to be very carefully made. So we don't forget that medical attitude can worsen or prolong unexplained medical symptoms. This is leading to an attitude in 2 stages. The first stage is to remove the symptom by isolation and simple or armed suggestion. By armed suggestion, I can say, for example, using a placebo. The second stage is to treat the origin, which can be a personality disorder. symbolic dimension, and you see here that you see something in these two canons. Because your mind is made in a symbolic way. And because also this is an erotization of relationships and what we see, which is, for your knowledge, one trait of the histrionic personality disorder. It's maybe interesting for you to know. Clinical case 8. So this is a girl, 14 years old, 9th grade, with a very dramatic history of incest with her father. This incest was only revealed when she gave birth to the baby. No one saw nothing until the delivery. After father's incarceration and placement of the baby, this girl showed relatively good adjustment. She went back to school, she was doing well. 5 months later, with the stress of school exams, we saw a depressive breakdown with conversions, massive conversions, loss of subconsciousness, theatrical agitation. During the follow-up, she often touched her cheek like this, always doing this when she was talking to me. And once I asked her, after some sessions, I don't understand why you do this. And she said, I don't know. And then 3 or 4 sessions later, she said, I know. It's exactly the same touch as the baby's skin before they took him. So this very sensory experience symbolically represented her limb that nobody thought about. We thought of her as a victim of the incest. We didn't think of her as a mother of this baby who was taken away because the law, if you don't know, maybe it's good to know that the law doesn't allow at all that the baby, fruit of an incest, remains with the same mother. So he has been placed. And I'll end with this other story with this boy, 7 years old, 2 abortions before his birth. His pregnancy was also very threatened by abortion threats, and his surname, Firas, was supposed to be given to his elder brother, but the family of the father refused, and they gave him another surname that you will see. He was consulting for excessive irritability and tolerance to frustrations, onanism, and he was masturbating, and multiple somatic complaints. So maybe you don't see it, but I'll try to read what's written here. So this is basically the drawing of a family. It's something that we asked kids to do at the first session. So this is the mother, Afika. This is the brother, Abd al-Haq. This is Firas, but something that was fading. He wrote Fi, and then he put like a line, and then Firas, and Abd al-Latif, the father. What I noticed is that the mother has got no shoes here. Abd al-Haq has got shoes. Firas, no shoes. Abd al-Latif, shoes. You see it? So I made a theory. I'll tell you about the theory. So after some sessions, the transference was very good, and I became Sayyid Naufal with shoes, and he was Firas without shoes. So my theory is that something was lacking symbolically, a kind of what we call castration symbolically. So related to the presence of something before the name, كلهم عبد الحق عبد اللطيف وهو فراس, and the shoes. So what we did is we invented the character called Abd al-Rahman, completely invented. And he was very excited in writing things about Abd al-Rahman, يسرق ويسحر الدجاج, Abd al-Rahman يكنس الغبار. And Abd al-Rahman, as you see, once he has got the Abd, he's got shoes. And then we did a lot of, funny stuff with this in psychotherapy sessions. And you see here, Abd al-Rahman يأخذ القلم من أخيه, which is very symbolically relevant. So, at the end, this child went very well, but this was the only thing I did with him. So if you see, for example, a picture like this, always pay attention to the small things. Why 3 flowers? Why something here? These are the most important things to be noticed when you deal with a child with conversions disorders. And usually the number of birds, the number of butterflies, why this tree is like this and this tree is like this. This says something about the personality of the child. So this says something also about the primary gains. These are les bénéfices primaires. These are not always seen during standard clinical examination. This is a compromise obtained by symptoms to solve an inner subconscious conflict, for example, Oedipian desire or rivalry, aggression, desire of aggression that has been not possible, reducing level anxiety, and masked fulfillment of a forbidden phantasm, which we know is one of the most important things when we talk about conversions. So conversions always occur on functions of relation, locomotor system, voice, hearing, sight, and so on and so forth. So the take-home message before I conclude, conversions are psychological attempts to control anxiety. Physical manifestations of anxiety appear when secondarization, this conversion, or any kind of other way to secondarize the anxiety fails. Be careful to symbolic expressions in play, in drawing, in role play, especially to face. So the diagnosis formulation should be on 3 levels: semiological level, diagnosis discussion, and psychological discussion. And this is corroborated by many theories. I'm not going through it. So to summarize and to conclude, classification of unexplained medical symptoms is a work in progress. We don't have, until now, something very convincing. Semiological are conversions and unexplained medical symptoms rather than diagnostic categories per se. It has an importance of context and symbolic aspects, and the diagnostic stage is already therapeutic stage. Thank you for that. Arrogant.
And you want lazy to ask a question. Do you want to ask a question now or at the last of the session? Have a question. So let's start. Someone has a question?
Thank you, Professor Berhoud. My question is about the evolution of children with histrionic features in adulthood.
Yes. Of course, the kind of question that is the kind of question that is obvious, but that I didn't prepare, but I have tried to. I didn't come across a study that was studying this from the beginning, I mean, from childhood to adulthood, because the concept of histrionic personality traits or histrionic personality construction, organization, like French people say, is not accepted, it's not endorsed by DSM and by ICD-10 people. So there's no study studying this in terms of describing with the new classification system. In French models, I'm not sure I've seen something very clear about that. But what we say, and this is probably coming completely theoretical, this is not coming from empirical studies. Like Sehlaim said, we have 2 major exams, 2 major sessions of exams, principal et de rattrapage. The first one is the 6 first years and the Oedipian period, and the second one is adolescence. So you may correct some of your histrionic traits in adolescence, and then it's getting probably to be something more stable.
My question is, okay, Dr. Gattuso was easy and arrogant, and you get to the presentation you wanted.
I can say it, you cannot say it.
And I was sneaky, I get you here today, and you will respond to my question, what is the relation with conversion and the different type of personality disorder? Can the borderline personality disorder have conversion symptoms, antisocial, or there is a personality type that don't do any conversion disorder and other more commonly have it?
Okay.
And in the DSM-5 you have no more hysteria. So what we call conversion related to a histrionic trait, what will we call it in the future?
Okay, so let me take my revenge by telling you that you have been lazy because I have been saying clearly that no personality organization is related to conversion. Conversions can occur in everything. So this is what is considered to be baseline. But it just happens to be more frequent in personality, histrionic personality disorder, or we see histrionic. But it's not at all. I mean, when you talk about childhood, it's clear. This is something that is really not, I mean, how to say, it's not associated necessarily to histrionic traits, and we see it in our practice. We have two, for example, seasons for conversions, and so unexplained medical symptoms. Now also for suicide attempts, unfortunately, is the seasons of exams, January and June. So this is very famous, and these kids are not necessarily histrionic, they are normal developing kids, but this is a way for them to cope with their stress. And as I mentioned, you have an anxiety, you use your, normal expression ways to take this anxiety out of you. You succeed at a certain stage, you have to do something else and you do conversions, and if you have nothing, so your anxiety kind of flooding and expanding without any kind of control system. This is more or less how I think we have to see things.
There's an aspect that you didn't deal with in the dissociative anxiety disorders is the time, the duration of the symptom. Conversion is universal, but it's not repetitive functioning of someone. Whereas dissociative and smartphone disorders become enduring traits of a person. So,
yeah. I don't have any precise answer to this. Maybe the timing for body and for the psychological aspect is not the same. But usually, you have very short associative aspects, but maybe because the DSM only mentions the amnesia, kind of prolonged the symptoms, but you can have lots, a very, very short, static or very short behavior that looks, completely conversive can be observed as well. I think probably when you use something in terms of dissociative adjustment system, probably it will take some more time. But I have no other, maybe I don't know if I can answer the question.
and for the Jeunes organizations, you have put the hysteria in 2016. We'd like to hear about it just after Dr. Jean. So I invite you to hear it tomorrow to have some answers with the other oral communication. Please go to the second presentation of Dr. Jeunes, the two phases of mass personality disorder. And at the last, at the end of the session, you can ask the other questions, okay? If you want, you can ask your question.
My question to Professor Gadour about despite the attempts to make the understanding of conversions and histrionic personality disorder not theoretically linked to the psychoanalytic schools, but we still see that the impact of this type of understanding is still influencing our understanding of the conversion and hysteria. My question is there any other theory, neurobiological or cognitive or genetic, which can explain these disorders?
Okay. Thank you. I just mentioned it very quickly on one of the last slides. Attachment theory refers to the proximity with the caregiver as an important factor that may lead to conversions, which function here is to keep the distance, the proximity with the attachment figure short and possibly acceptable. And the second theory that blends this is a systemic theory, and for example, may be an economic symptom in the family of a system, for example, to have somebody ill so that the system goes well.
Good afternoon, everyone. I'm not quite sure what was my mental state when I accepted presenting something counterproductive to do. But there is no turning back now, so I'll begin with this presentation named The Two Faces of the Narcissistic Personality Disorder. And as an introduction, I would say that the NPD, the Narcissistic Personality Disorder, is highly prevalent and is highly comorbid with other disorders. While there is a sizable body of work about narcissism as a noble trait, I mean from a psychosocial point of view, NPD has received very, very little empirical attention. As for 2016, there is not a single clinical trial that tested the efficacy of any pharmacological or psychotherapeutic intervention for NPD. We just don't know how to treat this disorder. Plus, NPT was nearly omitted from DSM-5. It was only kept for clinical tradition, just because we are used to it put there in DSM. So there is a great confusion regarding the specificity, validity, and sensitivity of the current diagnostic criteria of NPT. Plus, this diagnostic confusion surrounding NPT is due to the highly variable presentation of the disorder and the wide range of severity that can characterize it. People with NPT can be rich, poor, highly functioning, or functioning in a very poor way. It can be women, men of any age. So there are many questions one can ask about NPT. We're going to be asking mainly two of them today. First one is, are there one or many subtypes of NPT? Second one is, what are the differences and similarities between different potential NPT subtypes? So let's take a look at the diagnostic criteria, DSM-5 criteria. So NPT is characterized by a pervasive pattern of, and by pervasive we mean generalized or diffuse. So it's a pattern of grandiosity, which is an unrealistic sense of superiority compared to others. So people with NPT show a high need for admiration, high sense of entitlement. When I have a high sense of entitlement, I think that everybody has to do what it needs to favor me. All that I ask has to be done immediately and without any questioning. That's what I mean by entitlement. And people with NPT classically show a lack of empathy. And to know more about the social cognition process in NPT, I ask you to watch Mrs. Nif's, Dr. Nif's presentation tomorrow. So this is the NPT and DSM criteria. This definition has some positive points, gives an homogeneous definition of NPT. The other great point is that it captures the most important aspects of the disorder, but that current definition or current criteria have also some shortcomings. Excuse me. So the shortcomings. The definition gives an inadequate coverage of the broad population of receiving NPT diagnosis. It fails to cover some core psychological aspects of NPT, for example, vulnerable self-esteem, affective reactivity, plus, like all DSM criteria, it's only limited to observable features of psychopathology. But in DSM, we also find text, and I will cite some parts of the text in the NPT diagnosis. So it says, their self-esteem is invariably very fragile. Individuals with NPT are very sensitive to injury from criticism or defeat. Criticism may harm these individuals and may even feel humiliated, degraded, or empty. Empty, does that remind you of something? Yes. and sustaining feelings of shame or humiliation and self-criticism may lead to social withdrawal, depressed mood, dysthymia, major depressive disorder. So, it's as if DSM-5 we have the criteria, we have the text. Criteria seem to describe the prototypical form of MPD, the one we know. It's as if the text describes another subtype of another kind of MPD we don't really know about. So, there have been a few studies that examine these criteria of DSM to see what does these criteria look at, and generally these criteria find or explore two factors, and even studies that explore narcissism with other tools, not with DSM criteria, they find that pathological narcissism can be divided into two factors. It is as if there are two subtypes of narcissism in DSM criteria and in every other item or any other scale that measures narcissism. So, in literature, the normal or the typical type is named the grandiose subtype. It's also named the overt, which means the visible one. Sometimes it's called thick-skinned NPD, and by that we mean resistant. And there is at least one other subtype, which is called the vulnerable subtype, or covert, which means invisible, or thick-skinned, which means sensitive or fragile. So, it's clearly from a clinical and epidemiologic point of view that there are at least two subtypes that have some differences and some similarities, and we're going to start by differences. So, differences between the overt versus the covert. There are differences in terms of traits. So, the grandiose subtype is the typical one with overt grandiosity, attention-seeking, high sense of entitlement, arrogance, and very little observed anxiety or distress, while the vulnerable subtype is generally inhibited, hypersensitive to the evaluation of others, chronically envious, is not arrogant but chronically envious, and is in general manifesting distress. So these are different traits which may lead to different interpersonal functioning, while the typical grandiose subtype is socially charming. It is oblivious, which means neglectful to the needs of others and tends to be exploitative. The other subtype is generally shy, inadequate, chronically envious. He is not lacking empathy, but he is outwardly self-effacing, and by outwardly we mean in surface or in appearance. In appearance, he is self-effacing and submissive, which means which seems to be in contrast with the other subtype. And while the grandiose subtype may respond to humiliation with revenge-seeking or with hostile behavior, I mean, the grandiose subtype tends to react very actively when humiliated or when he's facing any stressful event. The vulnerable subtype tends to respond by denial, feelings of shame. He tends to give up, to engage in behavioral disengagement, so he tends to react in a more passive way. There are other differences. Generally, the grandiose subtype is a more adaptive construct. People with this subtype may have better functioning than general people with personality disorders, while the other subtype has frequently trait depression, trait anxiety, and tends to function less well. So these are the core differences between the two types of FPD, but there are similarities. And those similarities are going to permit us to say that the vulnerable subtype is, after all, the person with FPD is not, doesn't have another type of personality disorder. So, these two subtypes have a very similar sense of self, which is brittle, which means fragile, and flexible and removed from reality. that is in common, and both of them maintain a view of oneself as exceptional. Difference is that in the vulnerable subtype, the feelings of grandiosity are cloaked, which means are hidden, behind feelings of inferiority, which we call false modesty. But the grandiosity is there. In surface, those people demonstrate the opposite, but the real thought they have about themselves is that they are grandiose. And in both cases, both subtypes are excessively reliant on external feedback to maintain positive self-regard, but also to maintain self-definition. So these are points that say that those two subtypes have a very, very similar sense of self if we go a little bit beyond the observable facts. So, two subtypes also have very similar fantasies of unlimited success. So both of them are preoccupied with fantasies of personal attractiveness, brilliance, accumulation of wealth. The difference is the grandiose subtypes really believes that he can achieve that unlimited success. Sometimes he does achieve humble achievements, which will be exaggerated, while the vulnerable subtype lacks the self-confidence and initiative, and perceives that his fantasies are beyond his attainment. That's why generally he functions less well. Finally, there are similarities in interpersonal functioning. In both cases, interpersonal relationships are functional. They are here to support the sense of self, provide personal gain, and in both cases, there is a lack in the capacity of intimacy, because when a person with MPT engages with others in a genuine, in a real relationship, that's going to threat the stability of the grandiose self with oneself. So when I get in a relationship with someone, and I really see that the other has some value, that I'm not really superior to the other, it's gonna endanger the grandiose image of myself. So I will not engage in intimacy. If I have the grandiose type, I'll just engage in superficial relationships. But if I have the vulnerable NPT, I will totally withdraw from relationships. But in both cases, the mechanism is the same. And both are hostile. While the dominant, arrogant type is hostile, is aggressive, the other is hostile, submissive, and like told Dr. Zausch this morning, the MPT in its vulnerable subform may show some passive aggressive traits or behavior, which is a form of hostility, like you said. And in all the cases, in all instances, self-regulatory needs surpass the interests in others. So, but like we said today, the categories are really artificial. And in reality, we encounter NPT with mixed features. It means those people with NPT that can oscillate from one subtype to the other, or the NPT people that have at the same time features of the grandiose and the vulnerable subtype. Reality may resemble these more than the schematic separation between the two, and there are some clinical implications. We have to be precise. We have to know that there is the vulnerable subtype. We have to diagnose it first. There is difference in terms of treatment seeking, because the vulnerable subtype with the trait anxious depression is going to be asking for help more frequently. There is difference in terms of therapeutic report and treatment outcome. So I think it's very important to take into account those differences. And there is very clear implication for differential diagnosis, because while the grandiose subtype has to be differentiated from antisocial personality disorder because of the exploitativeness, and from histrionic personality disorder because of the need of admiration. The vulnerable subtype has to be differentiated from cluster C personality disorder because of the shy, inadequate presentation. So sometimes we may think of them as dependent patients or as avoidant patients. In both cases, we have to think of borderline personality disorder. It's a differential diagnosis for both subtypes at every moment of the pathology. That's it. I think that the dimensional model of personality, because of its flexibility, can be very practical to assess both subtypes of MPD. We may have the need to create specific criteria for the vulnerable subtype, and when we are aware of all of the subtypes, we can assess, conceptualize, research correctly this personality disorder to find an effective treatment. And as I said, there is not a single clinical trial on MPD. These are my references, and I thank you so much for your attention.
Any questions?
No, just about the variable subtype. It's just sensitive personality, classic sensitive personality, sensitive
I do think it's the same thing. I'm quite sure it's the same thing, but people with cognitive understanding of personality disorder tend to say that when you look at the schemes, that person, he actually thinks of himself as grandiose. So he's not that sensitive. Get me? In psychoanalysis, they say that people with MPT in reality or consciously think of themselves as very, very low value people, and that to react to this, they seem grandiose. From a cognitive point of view, we actually think that people with MPT actually think of themselves as grandiose. So, since sensitive personality is paranoid personality do think of themselves as superior. I think it's the same thing. I think it's.
I was thinking about
I think it's. I think.
Your second subtype is what we call
I think people stop talking about the sensitive for a known reason, and researchers started calling it vulnerable subtype of MPT. I think it's
the aggressive MPT and the vulnerable MPT are some. We share perhaps some psychodynamic.
yes.
But it's not the same narcissism.
It's not the same.
It's I'm speaking French perhaps because I don't know, narcissisme primaire and narcissisme secondaire are pas du même narcissisme dans les deux cas. I think it's not the same narcissistic profiles.
I do think that the sensitive personality of Kirchner is more, belongs more to the cluster B, more than, it resembles more the MPT, even if there are some differences. It resembles more MPT than it resembles paranoid personality disorder. That's my opinion after reading.
Psychotic personality. We discuss later.
Yes.
Do you think that with narcissistic grandiose type, do they go to the psychiatrist or
Just if they are depressed or if
in
they have.
hospitals or no, they present and I've been thinking why they came in personality disorder. Personality disorder must have stress, disadapted life. They are distressful for their bodies and for their families, but not unless they are depressed. When they are depressed,
Become.
that's the first depression. Generally latest depression after in the adult. It's not.
In general, it's a hostile depression.
It's a hostile.
Yes, it's a hostile depression.
Perhaps they will look like the second subtype
When they face stressful life events, and then they're gonna be on fire again.
So in how to identify and avoid a narcissistic person, because if you are good enough to identify them, you must run away. Thank you.
Welcome, dear colleagues. So, today we are going to talk about narcissistic purpose. So, we are going to start with case reports about two women who used to be married with narcissistic purpose. So, case one. Mrs. X, 60-year-old, divorced once further, father of a 30-year-old woman, met her second husband, Mr. Y, and her daughter's wedding. At the beginning of the marriage, Mr. Y was loving and in the small care with his wife. Mrs. X said that she finally found her soulmate. 3 months later, she reported the change of character of her husband. He became intrusive, verbally abusive. Then he started to squeeze her and tried to isolate her from her friends and family. He even seized her credit cards, her cell phone, and all her property, leaving her at his entire mercy. He sold the house furniture and even wanted to kick her out of her own home. She suffered less for depression and that's when her divorce ended. Let's move to case 2. Mrs. AD, 27-year-old, married to Mr. CD, 37-year-old. They were presented to each other by a common friend. They got married after 9 months of marriage and they lived together. At first, they seemed to be a happily married couple. She said she was the most spoiled wife ever. 2 months later, she was forced by her husband to stay at home to take care only of the business parts. She brought back a real-life experience of oppression, abandonment, and emotional carelessness. She was constantly decreased and lowered in front of people. She was also physically abused in secret. Now, she's fighting for divorce, having been physically assaulted and threatened with death by her husband. Thus, we have 2 women that turn out to be married to narcissistic perverts. So, what is a narcissistic pervert? Described first by Paul Academy in 1986 and made popular in the early 90s by Hitler and Goyen. The narcissistic perversion is a psychoanalytical term resulting from the association of 2 great emotions, the perversion and the narcissism. Neither international statistical classification of disease and related health problems (NCD), nor the DSM, nor the French classification for child and adolescent mental disorder (CHD-NDA) speak narcissistic perversion. According to Freud, narcissism is a necessary stage of development for the passage from the According to Freud, narcissism is a necessary stage of development of the passage from the autoerotism to the love of the object. According to DSM-5, it's the general mode of dreams or brain behavior need to be admired and lack of empathy, which appears at the beginning of the grown-up age. The pervert is someone who is arrogant and has a great sense of his own importance, Absorbed values of mental success, power, magnificence, beauty, or ideal love, thinks that he can be understood only by special and high-level people, needs to be admired, thinks that everything owed to him, uses the others to reach his needs, and envies the others, and thinks they envy him too. Freud defines the perversion as the expression of the drive of influence, and it shows itself in the relation to the object. Its psychic foundation is the denial of the difference between the sexes, which results in the denial of the other. So, according to Rakami, the pervert does not have a desire, but a need asking for an instant satisfaction. For him, the other one does not exist. So, how do they behave? First, they are obsessed with a self-image. They show excessive egocentricity. They play a double game. The narcissistic persons show themselves charming, seductive, brilliant, even accurate for the shop window. But in private, they are cynical, dark, and distracted. They use belittlement under the cover of humor at first, then more and more directly. They have no empathy and show emotional coolness. They are indifferent to the desires of the other, and they handle a missing version. This means that the dialogue on the topic runs usually in neutral. They give paradoxical and contradictory comments so that it is not. What does happen speaks about a real diversion of intelligence. They are incapable of apologizing or asking forgiveness except by strategy. They do anything to isolate their prey. They make you feel guilty and responsible for whatever turns wrong. They feel constant dissatisfaction and abnormal everything. They suffer from deep anxiety and do not support the well-being of their partners. They feel the compulsive need to waste any enjoyment around them and feel morbid relief when the other one is actually so. They invert the box and stay defective, and finally they suck out energy out of out. So the expression is that takes deal of sense. So, here's some advice to give to your patients in case they are dealing with a narcissistic pervert in the appearance. It is necessary to change the dynamics. It is more necessary to grab in the game of the justification of what we say or no. We're going to talk about it with someone we trust. But the ideal is to break any contact with you and your work. So in conclusion, being in connection with a narcissistic pervert is toxic. It's another estimated trouble, which needs to be more skilled. It can destroy the victim, causing them psychological scars. And the best solution is to end up with this kind of relationship is to run away, as far as it gets. So that would be the way.
Je peux parler en français, désolé.
I'm okay with that.
About the classification.
Yep.
Speaking about narcissistic pervert is not included in DSM and not included in the classification. But because the classification is based on psychopathology, and narcissistic pervert is not included in one case, in a case.
Yes.
Is it a pervert or is it a narcissist?
Okay, here comes the
Because psychopathology, we can't mélanger les choses.
Okay. In fact, the psychiatrists are divided in two groups. Those who think that there is a concept of narcissistic perverts, and the other ones think that the narcissistic pervert is even paranoid or narcissistic. So, if you want to, there is no medical concept for that.
Very good. C'est ça. There isn't a medical concept of it.
Yeah. but it's a trouble under screens in the society.
Media is named by the media. Named by the media.
You have to choose your view. So
I'm scientific.
Diverse people, I don't like to say patients, they are, when they commit acts, they are fully
Responsible.
responsible.
yeah, they're responsible for the act. Yeah. And usually they don't contribute to the operation department. You have heard about it.
Do you think the two cases is not that?
Yes. Great case.
Is there a link in the personality of the two women? No.
No.
You think that many women say I always have the same problems with men because I attract the bad profiles. I've always heard about this, and like she would have something responsibility of attracting the same profile of men. Is any woman as vulnerable to narcissistic?
Yeah, it's a trap where anyone can.
Anyone?
Yeah.
No.
Nothing.
No.
I don't think anyone.
That's why you have to screen them. And
Victims have similar profiles also.
yes,
Do you think?
no, I think that everyone can contact narcissistic service.
In contact, but not to get married. Why do some of them get married with these men with these profiles? What did you see in the first case and the same case that is not very different between the first and the second?
The behavior of the husband she says that to leave
What said the Dr. Afrafi is important in what? In psychotherapy. When a woman comes for depression and she speaks about a man with narcissistic, pervert narcissism, the first step of psychotherapy is to move from a victim statue to a reflection about ourselves. What is a reflection about ourselves? I repeat the same thought. When you ask the question in interpersonal psychotherapy about her ex, they are always pervert narcissists. Shows she is a woman who attracts that profile of man. This is important in psychotherapy.
I didn't say that.
You say that.
Narcissistic pervert marriage. It's her first. Well, the first time she was married to a
She will continue the same
Do the same
things until she will have a psychotherapy or until she.
What you say is very interesting. There's La répétition des scénarios de film. It's written by Couture, and it's talking about our schema, the schema du film. So in the psychotherapy, we are focused on our schema, the schema, and we move the patient from the victim person to responsible person.
Like the women who are beaten, always beaten by their ex. This is a bit the same thing. Like.
C'est la répétition des scénarios de film. C'est un livre.
We see that but now we have to go back to psychopathic personality. And with Dr. Bakiri, we are going to hear about some manipulation. It's your.
Psychopathic traits among the sample of Tunisian population, a bidimensional approach. Yes. Dear masters, colleagues, and friends, allow me to share with you my study and presentation entitled Psychopathic Traits Among the Sample of Tunisian Population, Bidimensional Approach. Psychopathy is a concept which was developed by Clicky in 1941, referring to individuals with antisocial behavior in those interpersonal relations are tainted with exploitation and manipulation. Followed by Robbins and colleagues, who developed another model of antisocial personality disorder, focusing on the behavioral aspect and lacking in personal contact. This model was unfortunately codified in the third edition of the DSM and remains in the DSM-5. Different approaches to psychopathy were made. To the categorical approach, we oppose the dimensional one. The most recognized today is the bidimensional approach. Here's Hare's model for the bidimensional model for psychopathy, which includes factor 1, interpersonal and affective phases, and factor 2, lifestyle and antisocial phases. The aim of our study is to detect the prevalence of psychopathic traits that we classified in low, mixed, or high among our sample, and see the gender differences concerning the different psychopathic factors and the correlations between the scores with age, educational level, and profession. We used, in a cross-sectional study, the level self-report psychopathy scale, adapted and validated in French according to the bidimensional aspect of the Hare psychopathic checklist, to detect clinical psychopathic traits among a sample of 739 Tunisian participants. The answers were collected anonymously via a Google Forms online questionnaire. So here is a quick view of our sample. It's composed mostly of young female adults between 21 and 40 years old, a high educational level, and the predominant professions are the medical and IT engineering. The score is composed of 26 items. The 16 first item represents primary psychopathy, and the 10 last items represent secondary psychopathy. We classified the scores according to Berkeley and Art into high, mixed or middle, low or non-psychopathic. Our results. We found among our sample more than half, 56.3%, showed high psychopathic traits, and 30% showed mixed psychopathic traits, and only 13.7% showed low or non-psychopathic traits. That means that almost 80% of our sample showed psychopathic traits. The primary factor is predominant among the high and mixed psychopathic traits group. And concerning the gender differences, men show significantly higher total scores than women. And when you look closer, primary factor was predominant among the male sample, while the secondary factor was predominant among the female sample. The most high scored significant items by men, where I will skip the item 4 because it's a problematic item. For men, it were item 5 and item 1, so making a lot of money is my most important goal, and success is based on in survival of the fittest. I am not concerned about the losers. And for women, it was item 20, I don't plan anything very far in advance. And item 25, when I get frustrated, I often let off my steam by blowing my top. So we noticed that the factors, the most high scored factors in the male samples were were included in the primary psychopathy list, and the most high scored factors by women were included in the secondary psychopathy list. No significant difference was found according to the age or the profession or domain. So let's take a second look at the Hare's Hare speed-dimensional model for psychopathy. Phases 1 and 2 include the interpersonal and affective aspects: superficial charm, manipulation, grandiosity, lack of remorse, lack of empathy. That reminds us of the narcissistic personality disorder. And factor 2 includes the impulsive parasitic lifestyle and antisocial behaviors. Studies show that, in fact, the narcissistic personality disorder is the most positively correlated to the primary factor of psychopathy, and cluster B personality disorders, particularly borderline and antisocial personality disorder, are the most positively correlated to the secondary factor of psychopathy. And if we see the correlations with the 5-factor models for assessment of personality disorders, primary and secondary factors are negatively correlated with openness, extraversion, and agreeableness. But the most important trait is neuroticism, which is positively correlated to the secondary factor while negatively correlated with the primary factor. That makes it the most important personality trait to distinguish primary from secondary psychopathy. Concerning the prevalence of psychopathy as a diagnosis in the general population, it's very rare, below 1%, and it's very rare among the psychiatric patients. It was mostly studied among the incarcerated populations and relatively frequent, especially in male subjects. Concerning the infraclinical psychopathy, our study shows higher prevalence than previous studies, with more than half of high psychopathic traits, which is very alarming, especially when we know that the sample is composed mostly of medical staff. So, concerning the gender differences, what does the literature say? Total score and primary factor are predominant within the male sample, while secondary factor, there were no significant differences found in literature between men and women. What our study failed to demonstrate due to the selection bias is that the prevalence of psychopathic traits tend to decrease during lifetime. In summary, psychopathy is rarely diagnosed in general or psychiatric population, and because of the secondary factors correlation with neuroticism, individuals with antisocial personality disorders are often in distress and are more likely to suffer from different psychiatric disorders, mostly anxiety and depression. And there is an important comorbidity between antisocial personality disorder and psychopathy, but the antisocial is not systematically a psychopath, so he needs our help and the emergency thing that we used to neglect. But still, even though population rate for psychopathy remains stable over time, studies show that while empathy levels decreased in student sample by 40% in the past 30 years, narcissism has radically increased over the same time frame. Also, in our study, men showed higher psychopathic and primary factor scores than women, which is consistent with the literature, but our findings suggest that the secondary factor is predominant in the female sample, which leads us to ask some questions. Is antisocial personality disorder underdiagnosed within female samples or overdiagnosed in male samples? And know that 75% of individuals suffering from bipolar personality disorders are female patients. Do we overdiagnose borderline and other cluster B personality disorders among women? And is there any influence of cultural and personal beliefs among the medical staff?
In conclusion, the high prevalence and scores obtained in our study may seem alarming when compared to the literature, but we must keep in mind that this self-report scale is a screening tool for features of infraclinical psychopathy among the general population and doesn't diagnose psychopathy, which has been mostly studied in the incarcerated population. Further investigations in a larger sample and reduced bias with an adapted and validated scale in our native language should be performed. Thank you.
Thank you. It was interesting, but thank you for your last sentence. It readdressed the results because I'm going to speak in Arabic now. I thought twins are called Khalid. If you have 80% that have antisocial traits,
Psychopathic,
psychopathic
not
traits,
behavioral aspects. This is what the whole study is about.
yes. If you give us this result without defining exactly what you did and what was your objective, what did you measure, in which language, was it validated or not in our culture? There is a phenomenon, you see it on social networks, on YouTube, Facebook. When you write in a language that is different of your maternal language, you have a certain distance, and you can tell things that are not becoming of your real personality and your real traits. So perhaps it was a survey on it's a Google form that they
Yes, the
tested.
studies show that online questionnaires are the same thing as if I did
No,
the
but
screening in
who
person.
is going to respond on this? How did you tell me something about the methodology? I didn't.
It's the levels self-report psychopathy scale. It's the version which is validated in French. It was validated in different languages, also in Portuguese and not only in French, but it was addressed mostly to French-speaking Tunisians. So it's a selection bias already. And I added some questions about the age, the level, the educational level, and the profession or domain, which were because of my Facebook about almost medical students and psychiatrists, and so it was the results may indicate the prevalence of psychopathic traits among the medical population. Even not really
on your Facebook friends representative of
739 people is kind of represented.
No, but we say about that in statistics, un biais de sélection.
Un biais de sélection, mais ça montre quand même que
Le biais de sélection, il biaise les résultats. Ou what Professor Afrafi have said about the validation in our culture. Is it validated in our culture?
It was addressed to French-speaking Tunisians. It wasn't validated in Arabic or in French. That's what I invited.
so it isn't a sample of Tunisian. It's important to
Sample of your
readdress the
Facebook
title.
contact.
It's not a sample of Tunisian population because there is a journalist here with us this night it would be online. 80% of Tunisian shows.
No, he would be wrong because I specified that it was about psychopathic traits and not psychopathy as a diagnosis.
And also the sample is not a sample of Tunisian PPs. It's not a sample of Tunisian people. It's a very good idea to make this kind of surveys, but perhaps you had the bias of selection.
Yes, I already mentioned it.
No,
Very big, yes, very big.
and it is very important. It's, hmm?
You cannot make these conclusions about easily. But the feeling after the revolution is that Tunisians have traits looking like Khalid.
Now,
It's a very
this is a
expressive-
judgment because Khalid is not systematically a psychopath. Psychopath can even be your boss or political person or
Yes.
everyone can be a psychopath. It's not the antisocial personality disorder who is focused
Yes,
on
I'm speaking about when I say
Not
in
Khalid.
Arabic term, Khalid is very
Yes.
expressive. It's not like in French or in English. It's
Unfortunately,
very
yes.
expressive. It's about the traits. It's what you are dealing with. It's not an social personality.
Yes.
No, it's someone. It's like you put the photo of the president.
Yes, and there is an article that talks about the wisdom of psychopaths, that saints and political persons who are psychopaths showed psychopathic traits. So it's not what we think it is, what we usually think it is. That was the only aim of the studies. It wasn't to really diagnose psychopathy among the Tunisian people because it would have necessitated.
We must stress this, just not to give you confusion about. It's very important to address what you want to
I specified it.
to do, how you did it. It was very clear how you did it, and then finally, what can be the conclusions for just what we did.
The aims and the methods were specified.
But it's not a representative.
Yes.
Okay.
Thank you.
I just wanted to say that I don't think that these results are that alarming because what we call psychopathic traits, we use a negative term to talk about, but we forget that now we live in a culture of narcissism. We live in a culture of you go and you get stuff, and these are traits that need to be in higher educated people that go into medicine, that go into engineering. So I don't think that these are really alarming results.
Yes, it is that we need all aggressive culture of defense. So
Any other questions? So we can close this session. Thank you. Okay, so I'm sorry. Dr. For obsessive compulsive personality disorder and affectivity. So now we are going to be more precise, and each term is going to be an obsessive definition of things.
I'm pleased to be here to present you this talk with activity and obsessive compulsive personality disorder. We think that there are non-affectivity or emotion. With the cats, he defines the emotion. He says 6 primary emotions: admiration, the equivalent of our time to the stamina, amazement, astonishment, surprise, love, hate, desire, joy, sadness, and all others are composed of some less 6. With Ekman, things are more developed and clearer. He defined the 6 basic emotions:
sadness, anger, contempt, disgust, surprise, fear. So we can't try to help. Emotion in everyday speech is any relatively free consciousness experience characterized by intense mental activity and a high degree of pleasure of displeasure. Emotion in often intertwined with mood, temperament, personality, disproportion, and motivation. That is very simple. Thoughts make us feel, and we can't have this behavior. So this led us to ask the question of particularity of emotion expression in the obsessive compulsive personality disorder, and that is in English. Obsessive compulsive personality disorder is characterized by expressive perfectionism, orderliness, and control. Symptoms include preoccupation with rules and details, rigidity, integrity, delegation, delegating tasks, overconsciousness, miserliness, excessive devotion to work, and the inability to discard worthless items. Although emotional constriction is a hallmark feature of OCPD, very little is known about emotional functioning in OCPD. The rigid of control of emotion characterized of OCPD stands apart from excessive emotion expressivity and affective lability of often present in other personality disorders. So, respectively, in the speed of thoughts, emotion are intense, unbearable, and something stifling. Emotion and feelings are expressed only in a controlled manner, limited, so little spontaneous and often inadequate. The person prefers to take refuge behind slight abstractionism. Tolerance of others from emotion expansive is very limited. So he feels uncomfortable with dramatic feelings, with dramatic situations. So he can't see the OCPD fears about his own emotions and attempts to control them. That's when control of a situation that fails to show will affect previously variants. In this case, 3 may be motor restlessness, deep nervousness, sarcastic, caustic, or character disorders ranging from irritability to the explosive temperament. This is most often disproportional reactions that deteriorate the quality of relationships. Emotional expression and constriction associated with the disorder reflect both underlying emotional difficulty that may deterioratingly affect function. The expressive need for interpersonal control often present in individuals with CPD has been shown to lead to interpersonal difficulty with spouses and partners. What's the risk factors? Problems associated with emotional difficulty in other personality disorders such as child abuse, anger, suicidality, and substance use are associated with OCPD as well. Child maltreatment has been implicated in the development of emotion function. In the large study, 72% of participants diagnosed with OCPD reported a history of childhood abuse, including 56 endorsing sexual abuse and 81% endorsing neglect. So what kind of emotions this OCPD person can control? First, the study of anger across the personality disorder found nearly identical rates of anger in patients with OCPD and those with BPD. Avoid personality disorder ranks first. Analytic study of OCPD symptoms have found aggressiveness along with perfectionism to be a core dimension of the disorder. Interpersonal rigidity is associated with anger and aggression in our patients with OCPD. OCPD has been associated with suicidal ideation and suicide attempts even after controlling for depression. In large and epidemiological study, 30% of individuals with OCPD met criteria for a substance use disorder. Study assesses domains of emotion functioning, negative affectivity, anger, emotion regulation, and emotion expressivity in persons with OCPD, and compared them
to OBPD, the borderline personality disorder group, and the healthy control group. They found that OCPD participants scored fall between of the BPD participants and the healthy controls. In terms of negative affectivity, participants with OCPD scored higher than healthy controls, but lower than participants with BPD. OCPD participants would score similarly to participants with BPD in the both of state anger, emotion regulation difficulty would be more pronounced among participants with BPD than participants with OCPD, given the severity of emotion regulation problems typical of BPD. However, we observe greater emotion regulation difficulties in participants with OCPD than healthy control based on the association between OCPD and child abuse, suicidality, and substance use. Lastly, participants with OCPD report less expressivity of both positive and negative emotions than healthy and BPD controls, because the lack of emotion expressivity is often considered a key clinical feature of OCPD. According to Vilmeret, symptoms such as rigidity represent attempt to manage underlying impulsive aggression. Participants with OCPD report stronger than typical general emotion response tendency. You can say reporting feeling their emotions strongly. They also endorsing 3 types of emotion regulation problems. First, difficulty accepting emotion. You can say, when I'm upset, I feel angry with myself for feeling that way. Second, difficulty achievement emotion clarity. I have difficulty making sense out of my feelings. And difficulty having access to effective emotion regulation strategy. When I'm upset, I believe there is nothing I can do to make myself feel better. They also endorse typical awareness of their emotion. I pay attention to how I feel. That capacity to attempt to and to acknowledge their emotions may reflect self-monitoring and vigilance of emotion aimed at keeping emotion in check. So he can control what he is not expecting. Emotions are the surprise for him. Preventing the drive prohibited from entering the consciousness, spread fear, and prevent any form of displeasure. The psychic structure has a remarkable feature as to help with a very active myself using many defense mechanisms: informant, reaction formation, environment, consolation, isolation, and preventive evidence. There is a mechanism needing to inhibit by psychic movements, either directly by refoulement, is by insulation, by abolition that what would generate, by the mind thought, preventive awareness, consolation, or by environmentally procedure, set and ritualize the drive. I have no surprise. I don't need surprise. I can support surprise. So just he can say to protect himself. He is not himself. So although not formally associated with emotional difficulty in DSM-5 diagnostic criteria, OCPD may be characterized by the difficulty in several emotion domains. In the absence of effective emotion regulation strategy, individuals with OCPD may resort to rigid emotion constriction and over-control, preventing learning of more adaptive and flexible emotion regulation strategy that may ultimately promote understanding and acceptance of emotion. Treatment for OCPD may thus benefit from including emotion regulation skills, such as dialectical behavioral therapy. So, overall, this finding suggests several avenues for research, including further exploration of the roots of anger, aggression, and other negative effects in OCPD, the contribution of comorbid condition as depression or anxiety and emotion functioning in OCPD. Thank you.
شوية